and severe corneal opacification, limited ischemia all over. Complication: corneal melting, severe corneal and conjunctival scarring, uveitis, glaucoma, and maybe lead to the loss of the vision in this eye. Like this chemical injury, which is very dangerous. Ocular chemical burn, continuity management, immediate irrigation with normal saline or lactic ringer lactate for at least 30 minutes until the pH is normalized, maybe require up to 8 liters. Do before checking VA or hospital or a history or an examination or fluorescein, and recheck pH 5 minutes later in order to be sure that his pH is normalized. After irrigation, check the visual acuity and complete the examination. Treatment: give any ointment like erythromycin 1 to 2 hours with cycloplegic atropine, and may need IOP lowering or steroid. Eye infection in ophthalmic neutrum is conjunctivitis within the first month of the life. Common causes is chlamydia, and this is from the cases presented to the emergency because this small baby and her parent is very fair, like chlamydia, trachomatis, and staphylococcus, strep, Neisseria, gonorrhea, and herpes. Sign: purulent gonococcal and or mucopurulent discharge, conjunctival injected, and eye edema, chemosis. Management: conjunctival scrubbing for gram-positive and stain, chlamydia antibiotic test, culture, blood and chocolate agar, and viral culture for them. Treatment with topical antibiotic, eye drop, and or ointment, and guided by the result of the gram and negative. If chlamydia trachomatis, treat with the systemic erythromycin, and since pneumonitis and otitis media can coexist with the erythromycin ointment 4 times per day. Acute conjunctivitis, the last, may be viral, chemical, bacterial. Conjunctivitis, mucopurulent discharge, viral watery discharge. Treat as bacterial, topical antibiotic, and expectation is the gonococcal, which is the required systemic antibiotic and topical drop. Viral supportive treatment with cold compressor and artificial tears, which is highly contagious for 1 up to 10 days. So we must be careful with the deal with this patient with the virus because it's highly contagious. Cellulitis. Cellulitis may be preseptal or orbital cellulitis. Common organism: staph aureus, staph epidermidis, or strep pyogenes, and Haemophilus influenza. Preseptal cellulitis involve soft tissue of the eyelid and preorbital tissue anterior to the orbital septum. Patient presented with erythema, swelling, tenderness, eyelid, and surrounding preorbital area. Orbital cellulitis, more serious infection, involved extension of the infection posterior to the orbital septum, which is more danger than preseptal. And the risk, it's danger due to the risk of the cavernous sinus thrombosis, and meaning that's brain abscess. Proptosis and ophthalmoplegia decrease vision, significant pain on the eye movement, and abnormal pupil, and decrease in the vision and the color vision defect. Like this, orbital cellulitis picture. Treatment of the cellulitis: mild preseptal cellulitis, oral antibiotic may be enough. Severe preseptal or orbital cellulitis, you must admit the patient and start on the IV antibiotic with a broad spectrum until the infectious agent is identified. Can add a topical antibiotic ointment. So we must ENT consulted if the sinusitis or mucopurulent, and if the patient is immunocompromised, consider mucormycosis and severe fungal infection with a black Jarska sign in the nose or roof of the mouth. Immediate surgical debridement and antifungal treatment. Thank you for attention.
Thank you. Thank you very much, Dr. Hisham, for your presentation. All the questions, it will be after the finishing of the session. We are, as emergency physician, really we are looking to deal with these cases in ophthalmology. With the pleasure to introduce our next speaker, Major Dr. Arij. She is family medicine specialist training fellowship in community medicine, master degree, working as representative of infectious disease at the Royal Medical Services. She will talk about public health emergencies in our Royal Medical Services. Please, Dr. Arij.
Good evening, everybody. Thank you, Dr. Ahmed, for introducing me at this sweetie way. And also thanks for organizing committee for a kindly invitation to me. And I'm really so happy and proud to be here with you today as a guest speaker. Today I'm going to talk about public health emerging disease, and I will give more details or focus on one disease of it, which is seasonal flu. And really I have chosen really flu, this topic, because you know influenza familial. Okay. I have chosen this topic because you know, influenza familial for all of us, and is constantly re-emerging disease because it's, as we know, it has genetic variation and rapid adaptation, which allow virus to serve up new strains each cold and flu season. And that occurs because immune system or our body is not primed to fight. Let's start. First, we must differentiate it between, both of it are epidemiological terms, which is emerging and re-emerging disease. Emerging disease defines as disease that have really appeared in a population or have existed, but are rapidly increased in incidence or geographic range. And the most important example, it's a COVID-19 of emerging disease. About re-emerging disease, we can define it as diseases that reappear after they have been on a significant decline, or re-emergence may happen because of breakdown in the public health measures for disease that were once under control. And the most important example for it nowadays, which is cholera. Cholera in most Middle East countries and all over the world, we can see more cases of cholera, but now in the Syria we have epidemics of cholera. And what we mean by epidemics, it's also epidemiological terms, it's occurrence of disease in normal of expectancy. And all the countries around the Syria or had refugees from Syria now prepare new guidelines to control these cases if we have more cases in our country. They can also happen when new strains of unknown disease-causing organisms appear. I will give more details about influenza, seasonal flu. It's RNA enveloped virus. It's related to family called Orthomyxoviridie. It's very, very, very small. This picture, it's under microscope. It's about 80 to 200 nanometers. We have more than 400 types of viruses, but we will focus mainly on the 3 types, A, B, and C. And about the B and C, we have not genetic mutation over it. More the mutation we can see with the strain A. So also we will focus on the serotype A. About the A, it have something which is called glycoproteins over the surface of the virus. Glycoprotein antigens, which is called H and N. H refer to hemagglutinin and N refer to the neuroaminidase. These pictures give us more details about how these glycoproteins present on the outer surface of the virus, and if we have any genetic mutations, it will be happen at these glycoproteins. In the influenza, how its mutation or that mutation happen? It through something which is called antigenic shift and drift. What we mean by antigenic drift and shift, at what's the main differences between it? About the antigenic drift, it's a show change. It's a slow change, and the main difference between the antigenic shift and drift, it's a slow change in the viral genes due to replicating error or random mutations result in the new virus strain, and that's what happened with seasonal flu every year. But about shift, it's rapid and large antigenic change in a virus and requires at least we need 2 different types or serotypes or strains to combine to form a new viral serotypes. Also, we have another name for it, which is called phenotyping change. And the most familiar example of us, what happened in the swine flu, H1N1 and H5N1. Let's give more details about influenza flu. Why it's important? Because we have every year about 9 to 41 million cases. And despite how common is it, it's a serious disease. And every year we have 450,000 deaths and about 650,000 hospitalization occur in all age groups because of it. We have high-risk group. We can see the more number of deaths in this high-risk group. Healthy children can die from the flu. The younger the child is the higher risk for serious flu complication. And this complication we can see in this high-risk group, which is older age than 60, younger age than 2 years, and if it's neonates, also we can see more complication with it. Also, any immunocompromised patient due any cause, they are on the chemo. On the chemoprophylaxis drugs. Also, patients with a chronic disease such as hypertension and DM for long period. They will suffer more if we have influenza flu, seasonal flu. So when we give a vaccine and talk about the flu vaccine, we will focus on this high-risk group. Young children are at high risk for serious flu complications such as secondary bacteria pneumonia, ear and sinus infections, and also dehydration. Now let's give you some information about seasonal flu. As we know, seasonal flu incubation period about an average from 5 to 7 days and average about 4 days. We have symptoms appear about 2 days before the patient will be infectious to others about 2 days before appearance of signs and symptoms. And about signs and symptoms, all of us are familiar with it, which is general weakness, headache, low back pain, also low-grade fevers, and بالإضافة اللي هي عندنا اللي هي respiratory symptoms such as productive cough. About the treatment of it, as we know, antibiotic is not effective for treat because it's viral, so we use antiviral. And the most important prophylaxis measures, which is اللي راح talk about اللي هو الvaccine, الفلو seasonal flu vaccine. Mainly we have 3 types of the vaccine. Contains اللي هي عندنا أول شيء the first weakened pathogens اللي هي life attenuated, which we called life attenuated vaccine, and inactivated, or which we called inactivated vaccine or killed vaccine. It's the same pathogen. It can't make us sick. And also we have, if we have made the vaccine from subunits of the virus, which is a smaller part of pathogen like an antigens. What's the main differences between 3 types? A life attenuated vaccine, it give us something which is called lifelong immunity. So in the future we don't need extra or booster doses of the vaccine. But about inactivated, we still need more doses and booster doses of the vaccine because it doesn't give us lifelong immunity. And about اللي هي subunit like طبعا اللي هو الانجريكس or hepatitis B vaccine, the most example of it. Life attenuated, the most example of it, which is the mumps, measles, and rubella vaccine. And the inactivated اللي هو seasonal flu vaccine, example of it. All vaccine mechanism of actions contains antigens which trigger the immune system to create specific antibodies, which is we called memory antibodies, and it will give a signal for pathogen destruction in the future. What's the benefits of the vaccines? It provides us protection from pathogens which can kill or make you sick. Also, we use this to control and eradication of once common pathogens like polio, smallpox. Polio, it's one of the re-emerging disease. It stops outbreaks and global epidemics, and that's what will happen with the COVID-19. The COVID vaccine, it have a great role to stop outbreaks and the global epidemics. About the risks and challenges we must know about the vaccine, we must know no medicine is 100% effective. So people can sometimes still catch the pathogen, but this is very, very, very rare. Side effects, maybe we have side effects, and we can classify it into local and systematic side effects. Local side effects such as swellings and fevers. And also we have the most dangerous side effects, but also it's very rare, which is anaphylactic shock, and it's need emergency. Not all pathogens have a vaccine. For example, still now malaria, it doesn't have a specific vaccine for it. The benefits overweigh the risks, so vaccines are given to people. We must give it. And also scientists work to make and improve vaccines. We will give more details about the flu vaccine. Who should get vaccinated? As I said, mainly focus on the high-risk groups. Who are high-risk groups? Everyone, we can give it for everyone 6 months and old. We have mainly two types of the vaccines. We have injectable one and nasal spray one, and I will discuss, I will give more details about the main differences between them. About that اللي هو هون بحكي I'll talk about the shot flu vaccines. Who should get vaccinated? Everyone 6 months and older can receive it, especially individual at high risk of developing flu-related complications, and or if you live with or care for people with high risk for developing flu-related complication, or if you are medical staff, so especially in emergency rooms, so you are always in close contact or direct contact with patients, maybe they are flu patients. What's the absolute and relative contraindication for the vaccine? Who should not get vaccinated? People who have severe allergy to chicken eggs, and because the vaccine is prepared at chicken embryo. Anyone who had known allergy to chicken pox, it's absolute contraindicated, so we must take a good history from the patient before give him vaccine. People who had a severe reaction to the vaccine in the past, people who develop Guillain-Barré syndrome after prior dose of the flu vaccines, and people with moderate or severe illness. People with moderate or severe illness, it's not, it's relative contraindication. We will wait until the patient gets well, and after that, give him the vaccine. About the nasal spray, the injectable vaccine, it does about 0.5 ml. We can receive it IM, and as we said, it's given to the age from 6 months to the 65 years, and it's a type of it, it's inactivated or killed. But about nasal spray, we are in Jordan, we don't have just injectable type, we don't have nasal spray, nasal spray vaccine. Nasal spray vaccine, it's life attenuated vaccine, so any absolute contraindication to any life attenuated vaccine should not receive the vaccine. And about nasal spray vaccine, اللي هم بياخدوا healthy people aged from 2 years up to 49 are eligible for this type of the vaccine, and absolute contraindication for it, they should get the flu shot instead. Adults 50 years of age and older, or children from 6 through 23 months of the age, children younger than 5 years with any of this condition, asthma or one or more episodes of wheezing within past years, the pregnant lady, because as I said, it's life attenuated. Injectable, it's safe for pregnant lady at any stage of the pregnancy. She can receive it from the first stage, from the first trimester of the pregnancy. people who have certain long-term health problems, muscle nerve disorders or weakened immune system. Also, anyone in close contact with someone whose immune system is so weak because it's, I said, life attenuated and they require care in the protected environment. Also, children or adolescents on long-term aspirin treatment. Does the shot cause the flu? It's the most common questions we received from the patient. The answer, no, the flu vaccine doesn't cause the flu. Maybe it causes flu-like symptoms, but it's not a flu. The viruses in the vaccine are weakened, as we said, it's attenuated or killed, inactivated, so the shot and the nasal spray won't cause you to get the flu. The vaccine will prompt your body to develop the antibodies necessary to fight, and it's the mechanism of action, as we said, of the influenza viruses, and a slight reaction to the shot, such as soreness, redness, hotness at the site of the injection, and maybe we have mild muscle or fever may occur. Thank you for listening.
Thank you, Dr. Arich, for your nice lecture. All the questions, as I said before, at the end of the session. With the pleasure to introduce our last speaker today, Dr. Attar Ali Mahmoud. He is consultant of emergency medicine, clinical lecturer, University Melbourne, director advanced life support in Australian Resuscitation Council, emergency medical service trauma, advanced trauma life support instructor, stream lead clinical service of clinical governments, and also Australian of emergency medicine. He will talk about transformative scenario planning in healthcare.
Previous page, it's laser, but old push.
Okay. Good evening, everyone, and it's an absolute pleasure to be here today, and thank you very much. Merhaba, that's the only word I learned from the taxi driver, so apologies and forgive me for that. Not learning more of Turkish. Transformative scenario planning. Transformative scenario planning, so what exactly is this? It's actually a very complex social technology that kind of uses all the existing social models which actually kind of use for change management in our healthcare system, but using various combinations of it. It's about a transformative leadership. It's about transformative facilitation, where we actually bring people together to bring this change. It's a diagnostication tool. When we are actually stuck in a situation, it's actually kind of, it works. We'll go through that later. So, unfortunately, with the kind of growing demands for the healthcare systems and our kind of limited resources, we are faced with the change management all the time. So when we actually have this systems change, processes change, or whatever that's happening, we either actually faced with this choice. Either we actually accept it, adapt to the situation, or we challenge the situation to change it. Unfortunately, there's not much room to say, I don't want to change, because then perhaps we may not be part of the system anymore. I found this maxim very helpful at times to me. Niebuhr was an American theologist of the 19th century. And he said, Lord, grant me the serenity to accept the things that I cannot change, the courage to change the things I can, and the wisdom to know the difference. The last line, I always look back to it. I want to know which I cannot change and which I can change. So in today's talk, what we're going to talk about is we're just going to talk about a bit of historical perspective about where this transformative scenario planning process actually has come in. We'll give a bit of introduction about how change management happened that you must all have faced in your institution, in your hospital, in your health service, in your country. We'll talk about my story that the grandparents' health, we kind of took a major endeavor there, and how we use this technology, these systems in our health service. And we do a bit of more delve into the principles of transformative scenario planning. Thanks to Adam Cahan. Adam Cahan done a lot of work, and he's one of the pioneers actually establishing transformative scenario planning. Adam Cahan, he used to kind of work first in the scenario planning division of Royal Dutch Shell Company. So Royal Dutch Shell Company was the 7th largest oil producing company at the time, and they had this division. This division of team would actually write different scenarios. So what would happen? What could happen? What may happen? And they would write these scenarios across globally, across regions, governments, political, geopolitical, wars. But their interest was, if something happens, what do we need to do? Their interest was money. And they also say that their interest had environmental impacts and all. Cahan worked in this division for about 2 decades. And he did not stumble across, he did stumble on the transformative process. It's purely by an accident. He was invited to Montfleur scenario planning meeting. This is the transitioning of South African post-apartheid government into the new government, into the newer systems. There was a lot of conflict, the conflict between the government, conflict between the rebels, the unionists, civil societies. Everybody had a different vision for how they want the change to happen, how they want the country to change. And there was a very famous joke at that time in South Africa. We are faced with only 2 options, a practical option and a miraculous option. A practical option is we all kneel down and pray to some angels come and take our problems away. And that was the practical option. Whereas the miraculous option was we all sit together and work and bring this change forward, and that was miraculous. So Cahan stumbled upon Montfleur. And then what he noticed that has changed, that has actually developed into transformative scenario planning process. He kind of worked after that in the Colombian transition, Guatemalan transition. He worked in Ethiopian, the conflict management. So initially it went on to the high conflict zones, then it actually came to some civil society movements, health movements. There's a lot over the next 2 decades. He has worked a lot, and if any of you interested, these 2 books would be very, very useful. I refer still often to these books, and it gives me always kind of a bit more insight about certain things. When I'm stuck, I don't know how I'm actually bringing this change. So what the Australasian College of Emergency Medicine did is they took Cahan's work, saying it's been applied in societies, it's applied in